We'll be breaking down all major concepts covered on the exam. Usually when we evaluate a medical diagnosis, there's this expectation of, like, mechanical precision.
Right, yeah, you break your arm, the x-ray shows that jagged white line right through the radius, and the attending just points at it and goes, well, there it is.
Exactly. It's broken. It's binary. The pathology is visible, the solution is structural, and you just move on to the cast.
But the moment you step into the world of neurology, and specifically cranial nerve disorders, that pristine x-ray machine is just utterly useless.
Oh, completely. We are suddenly navigating this diagnostic landscape that is incredibly murky. The symptoms are loud, but the underlying cause is hiding on a microscopic level.
Which is terrifying for the patient, obviously, but also, frankly, it's a massive trap for a Canadian medical student taking a board exam.
And as MCCQE reviewers, our mission here is to help you navigate those muddy waters. I'm Arvi, by the way.
And I'm Donna. We want you to feel incredibly comfortable and confident when you sit down for the exam.
Yeah, and to do that, this deep dive relies exclusively on reliable StatPearls articles. We want to ensure every single concept we discuss is high yield and, factually sound.
We should probably drop our mandatory disclaimer right here at the top, actually. This deep dive is strictly for medical education purposes only.
Right. It is absolutely not medical advice.
Exactly. Any clinical decisions you make in the real world must involve a qualified healthcare provider.
So today's focus is on a cranial nerve disorder, historically known as sciatic doloro.
Modern medicine calls it trigeminal neuralgia, or TN, but honestly, that historical name captures the misery of it perfectly.
It really does. Patients describe it as a literal lightning bolt striking them in the face.
And it's a highly testable condition because it requires these razor-sharp diagnostic skills. You have to distinguish the primary classic etiology from secondary, often far more sinister causes.
So we have to start with a clinical vignette.
Yeah.
Before you can prescribe a treatment, you need to recognize the presentation and understand the microscopic pathophysiology that's actually driving that pain.
Because the exam won't just ask for a definition, right? Examiners will construct a very specific patient profile to test your recognition.
Right, so picture the classic presentation. The vignette will almost always feature a patient over the age of 50.
And there is a distinct female predominance, usually sitting around a 1.5 or 1.7 to 1 ratio compared to men.
Yeah. The hallmark symptom is this sudden, severe, electric shock-like paroxysmal pain.
And that specific word, paroxysmal, cannot be ignored. We're not talking about a dull, throbbing ache like a sinus infection or a tension headache.
No, these are violent, short-lasting strikes of pain that hit multiple times a day and vanish just as quickly as they appear.
Anatomically, the pain is almost universally unilateral. It heavily favors the V2 maxillary branch and the V3 mandibular branch of cranial nerve V.
The vignette is also going to hammer home the concept of trigger zones.
Yes, this is huge.
The patient will have these specific areas near the midline of the face, usually the nasal or superior regions, where the slightest stimulus provokes an attack.
And we are talking about stimuli that shouldn't cause pain at all. Washing the face, applying makeup, shaving, brushing teeth, or even just like a cold breeze hitting the cheek.
When you see an innocuous trigger, like a cold breeze precipitating a 10 out of 10 facial pain in a vignette, it is nearly pathognomonic for trigeminal neuralgia.
You'll often see the patient presenting with poor dental hygiene or an unwashed face on just one side because they are absolutely terrified of touching that trigger zone.
Wow, yeah. So let's get into the mechanics, because understanding the why makes the presentation impossible to forget.
Definitely. In 80 to 90% of these classic cases, the root cause is vascular compression.
The trigeminal nerve root is getting physically crushed within just a few millimeters of its entry zone into the pons.
And the specific culprit examiners want you to identify is the superior cerebellar artery.
Right. That anatomical bottleneck is just the perfect storm. You have a highly sensitive nerve exiting the brainstem, and sitting right on top of it is this rigid pulsating artery.
And over decades, that constant mechanical battering from the arterial pulse physically strips away the myelin sheath that protects the trigeminal nerve fibers.
I always think of it like a short circuit in your house. The trigeminal nerve is this thick bundle of electrical wires inside the wall. Normally, each wire is wrapped in thick rubber insulation.
But because that superior cerebellar artery is constantly beating against it, the insulation wears completely away.
Suddenly you have bare wires touching. You flip the switch to turn on the bathroom light, which in this case is just a light tactile touch to the face. But because the wires are crossed, it accidentally sends a massive surge of power to the garbage disposal.
That is a great way to look at it. And the scientific term for that short circuit is ephaptic transmission.
Ephaptic transmission.
Right. When that localized demyelination occurs, you lose the insulation that keeps the action potentials isolated to their specific lanes. You end up with electrical crosstalk between the A beta fibers, which carry light touch, and the A delta and C fibers, which carry nociception or pain.
Wait, are these neurons forming new synapses with each other to pass that signal?
No synapses and no neurotransmitters are involved at all in this crosstalk.
Really? None?
None. That is the wild part about ephaptic transmission. The electrical impulse literally arcs through the extracellular space from the touch fiber directly into the adjacent pain fiber.
That's crazy.
Yeah, the A beta fiber fires because you touched your cheek, and the current jumps directly into the pain pathway, sending a massive shock signal to the brain.
There is also a fascinating alternative theory mentioned in the literature regarding this nerve damage, called the bioresonance hypothesis.
Oh, right.
It posits that the structural damage isn't just from blunt pulsating trauma. It suggests that when the vibration frequency of the trigeminal nerve matches the surrounding vascular structures, it creates a resonant frequency that physically shatters the myelin.
Like a singer hitting the exact right pitch to shatter a wine glass?
Exactly, but it's happening microscopically at the base of your skull.
That's wild. But whether it's blunt trauma from the pulse or bioresonance, the end result is the same, right? It's demyelination leading to a terrifying short circuit.
Yeah, that covers the classic picture. But the MCCQE loves to test the deviations. So let's look at the secondary causes and how to spot them.
The International Classification of Headache Disorders, ICHD-3, separates this into classical, which is the vascular compression we just covered, secondary, which is an underlying disease, and idiopathic.
And the physical exam is basically the ultimate sorting hat here.
For sure. If a patient comes into your clinic describing the most horrific, shock-like facial pain imaginable, you would logically expect their cranial nerve exam to show deficits.
Right.
But in classic trigeminal neuralgia, the focal neurologic exam is completely normal. Sensation is intact, motor function is fine, reflexes are present.
So a normal exam points straight to classic TN. But if I am staring down a dense 200-word clinical vignette on the exam, scanning for clues, what is the single biggest red flag that shifts the diagnosis from classic vascular compression to a secondary cause?
You absolutely need to look at the patient's age and their concurrent symptoms.
Okay.
If the vignette describes a patient in their 20s or 30s presenting with trigeminal neuralgia, your brain must immediately jump to multiple sclerosis.
Oh, wow. In their 20s.
Yes. The prevalence of TN in MS patients is between 1 and 6.3%, which is vastly higher than the general population.
Why does MS target the trigeminal nerve in that specific way? I mean, why there?
So MS is an autoimmune demyelinating disease of the central nervous system, right? It specifically attacks oligodendrocytes.
Okay.
Well, the trigeminal nerve root entry zone at the pons is the exact transition point where central myelin, produced by oligodendrocytes, hands over to peripheral myelin, which is produced by Schwann cells.
Oh, I see.
Yeah, MS plaques frequently form right at this transition zone, stripping the myelin and causing that exact same ephaptic transmission, but without any artery pressing on the nerve.
So the short circuit is still happening, but the insulation was eaten by the immune system, not rubbed away by an artery.
Precisely.
So if I see a young patient with facial pain, I am scouring that vignette for other MS hallmarks, like optic neuritis, ataxia, focal weakness.
Exactly. Any of those concurrent symptoms lock in secondary TN due to MS. Another major exam trap is bilaterality.
Right, because classic TN is almost fiercely unilateral.
Yes. If the vignette patient has shock-like pain on both sides of their face, you are dealing with a secondary etiology.
What about the branch involvement? We mentioned V2 and V3 are the usual suspects.
If the pain is isolated entirely to the V1 ophthalmic division, be highly suspicious. Isolated V1 involvement happens in less than 5% of classic TN cases.
V1 is a red flag.
Definitely. And returning to the physical exam, if you find actual sensory loss like a numb patch on the cheek, or if the corneal reflex is absent, or the muscles of mastication are weak, those are massive red flags.
Because those deficits suggest what? Exactly.
They suggest a space-occupying lesion like a schwannoma or a meningioma actively crushing the nerve and destroying the fibers, not just stripping the myelin.
Got it. Confirming this diagnosis is primarily clinical, leaning heavily on the history and that normal physical exam. But imaging is critical to rule out those secondary causes.
Yeah, you need an MRI and an MRA to visualize the nerve and the surrounding vascular structures.
But the standard MRI is not going to cut it here.
Yeah, it really isn't. The test of choice, if available, is a targeted, high-resolution MRI using Fiesta sequencing.
Fiesta. Fast imaging employing steady-state acquisition.
It sounds incredibly complex, but why do we specifically need Fiesta instead of just a standard T1 or T2?
It really comes down to slice thickness and contrast. Blood vessels like the superior cerebellar artery are tiny.
Right.
A standard MRI takes images in slices that might be 3 or 4 millimeters thick, with microscopic gaps between those slices. The vascular compression can easily hide in one of those gaps.
Oh, so you could literally just miss the compression entirely. Exactly. Fiesta sequencing gives you continuous 1 millimeter thick coronal slices without any skips. Plus, it creates a stark visual contrast between the cerebrospinal fluid and the solid structures of the nerve and vessels.
So the radiologist can trace the trigeminal nerve millimeter by millimeter through the prepontine cistern and see the exact point of contact.
You got it.
Okay, so classic TN is an older patient, unilateral pain, normal physical exam. Secondary TN is a younger patient, bilateral pain, or an abnormal physical exam with sensory loss.
Perfect summary.
So once we have the diagnosis and we've ruled out a tumor, or MS, we have a patient sitting in front of us in agony. Medical therapy is the first intervention, and this brings us to a massively testable pharmacogenomic concept.
It does. The gold standard first-line therapy is carbamazepine. It's an anti-epileptic medication, and it's actually the only drug explicitly FDA approved for treating trigeminal neuralgia.
Oxcarbazepine is frequently used as a first-line alternative too, right? With a slightly better tolerability profile.
Yeah, exactly.
At a cellular level, these drugs work by binding to voltage-gated sodium channels. They stabilize the channel in its inactivated state.
Right, and by preventing the rapid influx of sodium, they stop the nerve from firing those high-frequency action potentials. It literally cuts the power to the short circuit.
But starting this medication is not like flipping a switch.
No, not at all. It requires immense patience. You cannot just give a high dose immediately because the side effects will completely overwhelm the patient.
So you start very low and titrate upwards slowly.
Exactly. You can't even accurately assess if the drug is effective until the patient has been on it for at least 2 weeks.
It's like dealing with a rusted dimmer switch on a light rather than a circuit breaker. You have to apply steady, slow pressure to turn the current down, and it takes time for the nerve to stop hyperfiring.
Yeah, and because of that delay, bridging therapy is often required.
Right, like you might see gabapentin, phenytoin, or baclofen used to manage the pain while the carbamazepine is being titrated.
Baclofen is actually particularly interesting because it's a muscle relaxant, but it synergizes remarkably well with carbamazepine.
The exam, however, is going to focus intensely on the dangers of carbamazepine. You must know the pharmacogenomic trap here, the HLA B15.02 allele.
Yes, this is critical.
Why is this specific allele so dangerous, and who do we need to test for it?
So the allele is found almost exclusively in patients of Asian descent. If a patient carries the HLA B15.02 allele and you prescribe carbamazepine or oxcarbazepine, they have a profoundly high risk of developing Stevens-Johnson syndrome, or SJS, and toxic epidermal necrolysis, 10N.
The pathophysiology there is terrifying.
It really is.
The carbamazepine essentially binds to the peptide binding cleft of that specific HLA variant. The patient's immune system looks at this drug-protein complex, misidentifies it as a dangerous foreign pathogen, and just unleashes cytotoxic T cells.
Yeah, and those T cells directly attack the keratinocytes in the epidermis.
The patient's skin blisters, necrotizes, and literally slews off. There's a massive, life-threatening mucocutaneous reaction.
Which is why the strict rule for the boards in clinical practice, obviously, is that you must order genetic testing for the HLA B15.02 allele in patients of Asian ancestry before they ever swallow a single carbamazepine pill.
And even if they don't have the allele, you still have to monitor the standard side effect profile, right? Like drowsiness, dizziness, and hyponatremia.
Yes.
Wait, how does oxcarbazepine cause hyponatremia?
It actually stimulates the release of antidiuretic hormone that leads to water retention, which dilutes the serum sodium. So you are constantly balancing pain relief against dizziness and sodium levels.
That sounds incredibly tricky to manage. And eventually, for many patients, the carbamazepine just stops working.
Yeah, the nerve becomes refractory or the side effects become completely intolerable.
And when maximal medical therapy fails, The MCCQE expects you to understand the surgical ladder.
When pills fail, we move to physical interventions. And the options generally fall into two categories, decompression or destruction.
I think of it as rearranging the furniture versus cutting the power cord entirely. Let's start with rearranging the furniture, which is microvascular decompression, or MVD.
MVD is the definitive, most effective long-term treatment we offer. It boasts an efficacy rate of over 90%.
But it is a major posterior fossa craniotomy.
It is. The neurosurgeon opens the skull behind the ear, navigates through the cerebrospinal fluid to the brainstem, identifies the pulsating superior cerebellar artery, and carefully dissects it away from the trigeminal nerve.
And then they insert a tiny Teflon sponge between the vessel and the nerve.
Right. They are literally installing a shock-absorbing pillow to stop the physical battering, allowing the myelin to heal.
It fixes the root cause without damaging the nerve. But because it's a craniotomy, you're exposing the patient to the risks of a cerebrospinal fluid leak, meningitis, cerebellar hematomas, or ipsilateral hearing loss if cranial nerve 8 is disturbed during the approach.
Exactly. So if a patient is elderly, frail, or has significant comorbidities that make them a poor candidate for general anesthesia and open brain surgery, MVD is off the table.
So then we have to look at destruction. The ablative procedures, collectively known as rhizotomy.
This is intentionally damaging the trigeminal nerve root to permanently interrupt the pain pathways.
Right. You can perform a percutaneous rhizotomy by passing a needle through the cheek into the foramen ovale.
And from there, you can burn the nerve with radiofrequency thermocoagulation, poison it with a glycerol injection, or mechanically crush it by inflating a tiny balloon against the ganglion.
These procedures are highly effective in the short term, resolving pain in about 80 to 90% of patients.
But the recurrence rate is the Achilles heel here. At the 5-year mark, roughly 53% of patients will see their pain return as the nerve attempts to blindly regenerate.
There's also a non-invasive ablative option, right? Stereotactic radiosurgery, which is heavily associated with the Amma knife.
Yes.
But how does shooting radiation into the skull stop the pain?
You focus highly concentrated beams of ionizing radiation, usually around 70 to 90 gray, directly onto the trigeminal nerve root.
Okay.
It creates a localized necrotic lesion that interrupts the pain signals. It requires no incisions, but because radiation takes time to induce tissue necrosis, the patient might not feel relief for weeks or even months.
I have a massive structural question about these destructive procedures, actually.
Sure.
If you use a balloon to crush the nerve or radiation to burn a lesion into it, you are intentionally cutting the power cord. Dead nerve shouldn't feel anything.
Right.
Yet the literature warns about a devastating complication from rhizotomy called anesthesia dolorosa. If the nerve is dead, how can the patient feel pain?
It's a fantastic question, and it really comes down to central nervous system maladaptation. Anesthesia dolorosa translates to painful numbness.
Painful numbness? That sounds awful.
It is. When you destroy the peripheral nerve, the second-order neurons in the trigeminal nucleus inside the brainstem suddenly lose all their sensory input. This is called deferentation.
Okay, so the signal is just gone.
Right. And in response to this profound silence, those central neurons upregulate their receptors and become spontaneously, violently hyperactive.
So it's like turning the gain on a microphone all the way up because the room is quiet, and suddenly it starts blasting a deafening static squeal.
That is the perfect analogy. The patient's face is completely numb to the touch. They can't feel a pinprick or a cotton swab, but their brain is generating an intense, continuous burning agony that does not require a trigger.
Wow. You cured the paroxysmal lightning bolt, but you traded it for a permanent, agonizing burning sensation in a numb face.
Yeah, and because the pain is being generated centrally in the brainstem, it is incredibly difficult, sometimes impossible, to treat.
That is a terrifying risk, which explains why carbamazepine is pushed so heavily and why MVD, despite requiring a craniotomy, is the preferred surgical option for anyone healthy enough to survive it.
Absolutely.
Let's run a rapid-fire summary for the exam just to lock it in. You see an older patient with severe, shock-like unilateral pain in the jaw or cheek triggered by a light touch.
Diagnose: classic trigeminal neuralgia.
Initial step:
start carbamazepine, titrate slowly, and if they are of Asian descent, order an HLA B15.02 test to avoid Stevens-Johnson syndrome.
Perfect. On the other hand, you see a 28-year-old with facial pain, or an older patient with bilateral pain, an absent corneal reflex, or facial numbness. Diagnosis:
secondary trigeminal neuralgia.
Initial step:
order a high-resolution Fiesta MRI to hunt for multiple sclerosis plaques or a compressing tumor.
Awesome. The pathophysiology of this disease is incredible. The vascular compression destroys the myelin, leading to apoptic transmission. But the sources note something truly profound happening at the cellular level.
Oh, yeah, this is fascinating.
When that insulation is damaged, the local Schwann cells don't just sit there, they activate. They actively try to degrade the damaged myelin debris and begin secreting neurotrophic factors, frantically attempting to remyelinate those axons and rebuild the insulation.
It leaves you with a really fascinating thought about the future of neurology. Right now, our best options are masking the short circuit with sodium channel blockers, sawing open the skull to insert a Teflon pillow, or destroying the nerve entirely with radiation and risking anesthesia dolorosa.
Right.
But what if the future of treating trigeminal neuralgia lies in those struggling Schwann cells?
Could we eventually provide targeted biological support to the Schwann cells? Give them the exact neurotrophic factors they need to win the remyelination battle, repairing the insulation from the inside out before the apoptic short circuit ever causes a lightning bolt of pain.
It changes the entire paradigm from structural damage control to cellular regeneration.
It's definitely something to keep in the back of your mind as you memorize the pharmacology and surgical risks. Keep reviewing, trust your knowledge, and we'll catch you on the next deep dive.